it's been my privilege as an examiner and more recently as a tutor on various exam preparation courses to hear the sorts of things that trainees are struggling with when they are finding this difficult. And I think in the early stages of learning how to consult, people can be over-taught. There can be too much instruction going on. Remember when you were learning to drive, the first few driving lessons, all doctors take risks. Of course they do. I mean, surgeons take clinical, sort of technical risks. But general practice is often dealing with things that are so uncertain. Illness in its early stages, illness that's atypical. About 10 years or so ago, I had a small heart attack, from which I'm obviously fully recovered. But I take the usual amount of stuff that people take, beta blockers and all the rest of it after that, which means that once a year I have to get my repeat prescription reauthorized. And some years ago, I made the annual appointment for my prescription review. My regular doctor wasn't there, and the receptionist said, "Would you mind seeing the trainee?" Of course not. So I went in to see this poor girl who clearly recognized my name. And she said to me,
"My guest today doesn't need any introduction. He's a one and only Professor Roger Neighbour, considered to be a legend among many GPs. He has also written Consulting in a Nutshell, among other books that's been really useful to general practice. He was a former president of the MRCGP and former MRCGP examiner. Welcome to the channel, Roger. How are you doing?
Well, thanks, Owen. It's very nice to be with you.
Tell us, how did you get into psychology?
It's an interesting story. I mean, looking back, we probably all have moments in our lives when things actually pivot, and you don't always realize it at the time. But looking back, there are certain sort of moments where life goes in an unexpected direction. And I was lucky enough, I got a place at Cambridge. I went to read medicine at King's College in Cambridge, which was a delight. And on the very first day there, my very first day, I had an interview with my director of studies in medicine. He was a chap called Kendall Dixon, lovely guy. And we were talking about how it was going to be, what would happen in the first term and how things were organized. And he said to me, Roger, in the first year, you'll do anatomy and physiology and biochemistry. And then in the second year, there'll be some pathology and more anatomy and stuff. And I didn't like the sound of that, because in particular, I didn't really much like the sound of biochemistry. I'd done chemistry A-level, as one had to, but I didn't particularly enjoy it. And looking at the biochemistry syllabus, it all seemed a bit turgid. And I'd actually read the small print of the regulations. And the regulations then said that in the first year, medics had to do anatomy and physiology, but then there was a choice. You could either do biochemistry or history and philosophy of science or experimental psychology. And I thought I'd rather do experimental psychology rather than biochemistry. So I told Kendall this, and he said, "Oh, no. He said, no, medics do biochemistry. The psychology option, that's for the natural sciences, but medics do biochemistry." And I said to him, "Well, that's not what it says in the regulations." And to his credit, he indulged me. He said, "Okay, well, if you insist, then don't do biochemistry, do experimental psychology." So I and one other person in the entire university didn't do biochemistry as part of our basic medical training, but experimental psychology. And it was brilliant. It was absolutely fascinating. We ran rats through mazes at one extreme, and we had lectures on adolescent psychoanalysis at the other extreme, and everything in between. It was absolutely fascinating. So I've gone the whole of my medical career not knowing a thing about the Krebs cycle or biochemistry, but I did develop a real interest in the psychology. And if I'm honest, I think having that as a kind of safety valve, as an alternative to the really hard science, I think that probably kept me sane and helped me cope with the really unpleasant task of learning anatomy and physiology, which I'm sure you remember only too well. And that interest in psychology has stayed with me. So when eventually I found myself, some years later, going into general practice training, I'd still carried that interest in psychology. And of course, in general practice, as you know, so many things that happen in general practice are the expression both of the patient's psychology and also of the doctor's psychology. And so that was one strand, I think, that led me to start thinking in terms about what was happening in the doctor-patient relationship and how that played out in terms of the way consultations unfold. So it all goes back to an 18-year-old moment of rebellion.
So what motivated you to pursue a career in general practice?
It would be nice to say all the things that young doctors often say about loving science and wanting to work with people and all that sort of stuff, which is of course true. The honest truth is I didn't particularly enjoy any of the hard hospital subjects to the exclusion of others. I enjoyed everything as I went along, but nothing really captured me in terms of wanting to devote my whole life to an organ system or a piece of pathology. And I suppose also, to be honest, lifestyle things come into it too. My other life outside medicine has always been music. I've played the violin since the age of 4. And at the time I was a medical student, I had an extremely active life playing music with my friends, and I didn't want to be too far away from them, and I didn't want to have too little time for that. So that, if I'm honest, that came into it. But that was back in the 1970s. I started my GP training in 1972, when, of course, vocational training was only just getting off the ground. It wasn't compulsory at that stage. It was a voluntary arrangement. And I was lucky enough to get in on the ground floor of a vocational training scheme in Watford, which was my hometown. And I was one of the first 3 GP trainees who were accepted into that scheme. And the course organizer, as they were then called, program director now, was a chap called Peter Thompson, who became my trainer and my friend and ultimately my partner in practice. And he also had a great interest in the psychology of general practice. He'd been a member of one of the original Barlint groups, which, of course, I don't know whether you all or listeners are familiar with, but there's a great tradition in this country of Barlint group reflection upon doctor-patient relationship, and Peter had been very interested in that. And that I guess was another of those pivotal moments, because Peter Thompson, my trainer, had been on a course for trainers run by one of the then lions of general practice called Paul Freeling, who had run a modular course for trainers. And my trainer had been on this course and he loved it. And he must have sensed some interest in medical education on my part, because when I was still a trainee, my trainer sent me on this course for trainers, which was quite unusual. I was by far the youngest, and everybody was very kind to me and indulged me. But I learned a huge amount about not only about medical education, but how to teach and think, and how to combine experience with theory and technique, educational technique. And I think that was another very formative experience.
That's fascinating. Yeah, I can see that your education in psychology does bring up a different angle in the consultation. What has your perspective been on the consultation, and how has it changed over the years?
It's interesting, that, isn't it? Because the United Kingdom has probably got the strongest tradition of anywhere in the world of thinking and theorizing and studying the consultation and its dynamics. Most other English-speaking countries, I don't include America in that because they only speak a form of English, but places like Canada, New Zealand, Australia, all have a strong tradition of thinking about the consultation. And it comes down to what was going on in Britain, I guess, in the 1960s, when Barlint first came and started thinking about the consultation. That was unique in the world. Most of the standard literature, I suppose, if I could be immodest enough to include perhaps my own first book on the consultation, which was called The Inner Consultation, is part of that tradition. And most of the standard works around the consultation derive from the 1970s and from the 1980s, really, with Bernard Long, the Pendleton book. Pendleton group were the ones who introduced ideas, concerns, and expectations, and all that language that we're now familiar with. All those books were written in the 1980s, which of course was a much more leisured time than we are now. And they were also written long before consulting skills became part of the MRCGP exam and therefore an exam topic. So I think a lot of the thinking and the theorizing around the consultation dates from a time when people had more time to be thoughtful. and life was not so pressured as it now is in general practice, and also from a time before the consulting skills became an exam topic. And I think two things are probably are driving development at the moment. One is clearly the enormously increased time pressure that GPs are under these days of trying to get the job done in what is really a laughably short amount of time per consultation. And also, of course, for younger doctors who are having to qualify now that MRCGP is a compulsory exam, it's a licensing exam, as you know, you can't practice without it. And consulting skills, I think rightly, are part of the curriculum for that. But young doctors now, of course, are having to develop their consulting skills, not just for their own sake, because it's helpful in the consultation, but also because they've got to pass an exam in it. And that's introduced a whole new dynamic. I guess it makes some people slightly resentful of being made to think about these sorts of things. And also, I think it's driven quite a lot of the way in which consulting skills are taught almost as a kind of booky subject rather than an exploration of a real interaction between two live people. I think that those two forces, the fact that it's accessible and the fact that we're under much greater pressure now, those have been the forces that have, I think, driven a lot of my more recent thinking about the consultation, which is why as you were kind enough to mention my most recent book about the consultation, which I've called Consulting in a Nutshell. I wrote that about 3 or 4 years ago, really in order to try to capture from the amount of experience that is out there about the consultation, and to bring that into a more manageable form that could be handled, as it were, more easily by the present generation of young doctors who've got so much more pressure on them than they did in my day.
A contribution that you made, I understand, is giving safety netting advice, which is now a standard practice in general practice. So what led you to introduce that concept, Roger?
If I'm honest, Erwin, I really can't remember, except that I think all of us, certainly myself, and I'm sure you and virtually everybody who listens to this, will have had the experience at the end of a consultation of thinking, gosh, I just about got away with that. I nearly fell into a trap. That could have so easily gone horribly wrong. And it's the nature of general practice. All doctors take risks. Of course they do. I mean, surgeons take clinical, sort of technical risks. But general practice is often dealing with things that are so uncertain. Illness in its early stages, illness that's atypical, people whose presentation is different from textbook. Risk is all around us. It just seemed to be part of the consultation to always to be kind of not looking over one's shoulder exactly, but having in the back of one's mind, I could be wrong about this. This might go wrong. What would I do then? And so I introduced the idea of safety netting as being a key element, I think, of every consultation. I think really from the point of view of protecting not just patients but also us as well from because that the fear of making a mistake can although it's a necessary break, if you like, on bad practice, it can, if it's overdone, it can drive people to an excess of caution, over investigation and so forth. And again, if you'll forgive me for being immodest, it's one of two things I'm genuinely proud of having done. The idea of safety netting, which, as you say, has become part of standard vocabulary now, and the other thing which was I also introduced in my first book was the idea of housekeeping, the idea that we ourselves as doctors are enormously powerful instruments. Our personalities have a therapeutic effect. The patient affects us. We take on board a lot of emotional stuff from patients, and that's part of what lends general practice its empathy. But just as you get just as you clean the dust out of your stethoscope earpieces from time to time, it's important to keep ourselves in good shape. And so that notion of housekeeping, of making sure that we keep ourselves in good trim, I am, if I'm honest, I'm quite pleased that also has become a bit of standard jargon in the trade now. The other stuff about how you run a consultation, lots of other different authors have got different ways of expressing essentially similar ideas, and they all come down to something that's not particularly complicated. You listen very carefully to your patient and try and work out what the problem is, and you make sure that you get the medicine right, and then you try to arrive at a management plan that's good medicine and also satisfies the patient. The broad thrust of a consultation is pretty much standard, and different authors have described it in different language. But that idea of safety netting, of particularly trying to keep your patient safe, and to guard against uncertainty, and housekeeping of not neglecting one's own self-care. I think those are important features too.
That's great that you're highlighting the housekeeping. General practice is very stressful and can be draining. One of the things that's creating some anxiety among trainees is a new SCA exam. I don't know whether you had a chance to look at what the college has published. What are your thoughts about preparing for the SCA?
Yes, it's interesting. Again, not to go over too much recent history, but obviously because we now have a generation of trainees coming through general practice training whose whole experience of general practice has been post-COVID. And I think those of us who've been around in medical education for a longer period than that, I think sometimes realize that the present generation of trainees are not seeing general practice at its best. We're still seeing it in its recovery phase from the traumas of the COVID epidemic and the adjustments that were necessary. Prior to COVID, as I'm sure you'll remember, the MRCGP exam had a component called the CSA, the Clinical Skills Assessment, which was, in essence, a role play. It was a structured role play of 13 cases, and candidates had to turn up at Euston Square in London and submit themselves to a role play surgery of 13 consecutive role play patients, each accompanied by a silent examiner with a clipboard who would sit silently making notes, which was fairly intimidating. And then, of course, when COVID struck and face-to-face consulting of any kind almost overnight was a no-no, it was very rapidly replaced what many of your present and recent trainees will have been familiar with, the RCA, the Recorded Consultation Assessment, where trainees submitted live recordings of their own live consultation with real patients, and those were assessed. And I think that was pretty miraculous. And I think the work that went into that has not really been as widely appreciated as it deserves to be, because normally to develop a whole new module of a licensing exam, a high-stakes exam, would take a couple of years at least to pilot it and calibrate it and do all the stats and so forth. They managed to do it in 6 weeks to develop the RCA. Had they not done so, a whole year's worth of trainees would have found themselves unable to qualify. That would have been a disaster. And so the RCA, although it has many weaknesses, not least to do in terms of standardization and trying to compare one candidate's choice of patients with another's, it has many weaknesses, but it was actually a lifesaver. And you asked about the SCA, the simulated consultation assessment, which is coming on stream, all being well, this coming November. In essence, it's going back to the CSA, but being done online. It's a series of role play consultations, 12 this time, 12 role play consultations. Most of them will be video linked, but the candidates will do them from their own surgeries or from a nearby surgery. They don't have to come to London, which ought to be good news, because they don't then have to pay train fares and worry about strikes and so forth. But essentially, it's the CSA, but done over Zoom. I've had a certain amount of knowledge of how that's been developed, and I think it's going to be great. It's like it or not, the GMC insist that young GPs have their consulting skills assessed, and that's quite right. This, I think, is getting the best of both worlds. It's getting the reproducibility of the old CSA, so that it can be as fair and valid and reliable as possible, but much more convenient for the candidates who won't have to travel. And so I think it's going to be great. You and I can say that because we don't have to do the exam ourselves, but and also it will be a bit cheaper.
Yeah, I think the RCA is very intensive for the trainee because they're having to collect these cases over a month,
Yes,
whereas the SCA, it can all be done in one day. But there will be some people who might not feel well on that day and they'll still have to perform. So there's also that part of it with the SCA where somebody needs to be very well prepared for that day because that's a big day for their career.
yes. I'm not sufficiently on the inside of the organisation now to know how people would how the organisation would respond to somebody who was unwell on the day. But what I do know, and I don't think I'm being too chauvinistic about this, I do know that the college and the exam staff are not the enemy of trainees. They are not trying to make life difficult for them. They lean over backwards to try to be helpful. So we routinely make allowances for people who perhaps have physical handicaps or who are perhaps dyslexic. And so I'm pretty certain that the staff of the exam department will do their very, very best. But it's in everybody's interest. We all need more doctors, for heaven's sake. It's in no one's interest for anybody, let alone the college, to put unnecessary obstacles in the way of young doctors qualifying and entering our profession. Heaven knows we need everyone that we can get.
Absolutely. One of the things that you written about in the book is attentive curiosity. Some people, when they're listening, they don't have this trait when they're listening. How can somebody develop that?
Yes. Um, I think I'd like to turn it around the other way over and actually say, what is it about an exam setting where you forget all your normal consulting skills? I mean, most of the ingredients of a successful consultation, apart from knowing your medicine, which of course is vital, we have to know our medicine. But in terms of how you talk to another person, find out what's going on in their minds, and try to join them and have something helpful to say, you do that all the time with friends and family. I mean, if you have a child who comes in from school in tears or looking furious, you don't have to read a book or go on a course to be told how to be interested and want to find out. You just do it because you're used to talking to people and you're concerned with this person. And I think we those of us in the consulting skills industry, if you like, have probably made too much of a meal of this. Um, and you pick up on that attentive curiosity, and I think that really is it in a nutshell. Uh, if on the one hand you have a decent grasp of clinical medicine as a resource for you to draw on, which everybody does, you know, all GP trainees have been well schooled in clinical medicine, and just combine that with the sort of kindness, interest, concern, compassion, whatever, that you would quite bring to a friend or family or somebody that you cared about. Combine those two things. You don't have to worry too much about the techniques, about asking open questions and parroting and ideas, concerns, and expectations. If you bring to the consultation your own curiosity to find out what is it that's made this person come to have this conversation with me, what is it that they want to tell me about? I have a nice story about this. Some years ago, I had a problem with my left ankle, which was painful. I genuinely didn't know what the problem was. It wasn't a repetitive strain as far as I could tell, but it was getting worse. And I thought, I really need to see somebody about this. So, slightly against my better judgment, I made an appointment with an orthopedic surgeon. And we're all aware of some of the stereotype prejudices that people have against orthopedic surgeons, who are, shall we say, are not generally noted for their people skills. But I went to see this orthopedic surgeon thinking, I'm not bothered about his consulting skills. I just want to know what's the matter with my ankle. And when I went in to see this guy, who didn't know I was a doctor, I don't think he even read GP's letter. But his first words to me were these. He said to me, "Tell me what you want me to hear in your own words. Tell me what you want me to hear in your own words," which I think is brilliant. I don't know a better way of starting the consultation than that, to say to a patient, either in those words or something very similar, "Tell me what you want me to hear in your own words." What he was saying by that was, look, I know you've got something on your mind you want to get off your chest and tell me about. I'm listening, go for it. And that seemed to me to be exactly the right attitude. And that attitude of attentive curiosity carried through into the consultation, most of the words find themselves if that's the attitude that's driving you.
I think the attitude, having an open mind and wanting to learn from the patient's story from the beginning helps. One of the things that GP trainees struggle with is the fact that patients are coming with so many problems that if they're listening, then they find it difficult in terms of how they navigate the consultation with the complexity that we're getting. What are your thoughts about anything that could be done to help them with that?
Yes. I think it's almost the case now that virtually every consultation now has more than one issue, and that's no one's fault. Well, it's certainly not the case, certainly not the doctor's fault, it's certainly not the patient's fault either. Even the patient who brings several things, they're all usually legitimate things to want to bring to a doctor, and it's not the patient's fault that we are short of time. That's not their fault. But in terms of how you manage the consultation, in general terms, the earlier you can find out in the consultation that there are multiple problems, the easier it is then to plan your time and to either prioritize or to deal with them. So part of what I would think is important to establish in the early part of the consultation, which in my most recent book I've called the patient's part of the consultation, the patient-led part. If you can find out what the full agenda is early in the consultation, it's better to find out that there's 3 things on the patient's list at minute 2 than it is at minute 9, at which time it's you've left it too late to do anything about it. And there are ways of weaving that into the conversation. By saying to the patient, was that it for today, or was there anything else on your mind before we carry on? Was this the main problem? And patients are not they're not liars. They don't set out to trick us or to make life complicated. But again, I think there's a point which is also worth making. This isn't the place to go too much into the politics of it, but one of the features of a good consultation is to make sure that you solve the right problem. And it's sometimes very easy for us to think the problem is A, but it's B, or it's A and B. And the same applies at a greater level too. No amount of consulting skills training or consultation models or any of that sort of stuff, none of that is going to solve the fact that there aren't enough GPs in the country at the moment. Virtually all the problems that we have in general practice would be immeasurably improved if there were 50% more doctors. If we, instead of 10 minutes per consultation, if we had 15, that would be so much easier. If patients could see their doctors more readily, that was a great amount of the present difficulty. So we have to make sure that we're solving the right problem, and consulting skills are not going to solve the shortage of doctor problems. That's an entirely different agenda. It doesn't belong in perhaps necessarily in this conversation. But what you can do in general practice consultation is to make sure that you do concentrate on exactly what you're dealing with. And sometimes the problem that a patient brings to you, it isn't necessarily the first thing they say. People may need a little while to get round to the main issue, and the problem that has to be solved, it may not be the one that we'd like it to be, the convenient one. It may not be the one that NICE guidelines would like it to be. It may not be the one that the punctuality would like it to be. It may not be the ones that your off agenda would like it to be. We have to be willing, I think, in the early stages of consultation to keep our minds as open as we possibly can as to what it is that the individual patient wants from this consultation, and not necessarily to move on to trying to solve it until we really are as clear as we can be that this is the nub of this particular conversation. And I think a number of consultations that go wrong, that end badly with one party or the other feeling unhappy, do so because the doctor has tried to make the problem one thing, whereas really they should have been concentrating on something different. And that, I think, consulting skills do help with trying to listen between the words, to read between the lines.
Are you enjoying this video so far? If you want more insight every week, then you might be interested in Fulfill Friday. This is a weekly newsletter in which I share exclusive insights on things I'm thinking and what I'm working. This is what some subscribers of Fulfill Friday have said. Join over 700 subscribers so you don't miss out on exclusive insights every Friday. Click the link down in the description below. It's completely free. As somebody who plays violin, you probably have an ear for various instruments, and Listening is something that not everyone can do it very well. It's something that you probably have experienced among trainees when you were an examiner. What do you think are common pitfalls people make in the listening and not picking up cues?
What usually gets in the way of doing that is too much of our own internal dialogue. Uh, uh, and it's been my privilege as an examiner and more recently as a tutor on various exam preparation courses to hear the sorts of things that trainees are struggling with when they are finding this difficult. Um, and I think in the early stages of learning how to consult, people can be over-taught. There can be too much instruction going on. Remember when you were learning to drive, the first few driving lessons, you were thinking, pressure on the wheel, which is the clutch, and how do I change gear? Don't forget mirror signal maneuver, hand, all that stuff going on. The internal conversations you'll have with yourself, they actually get in the way. And it's really not until that internal noise dies down that you're free to direct your attention more outwards. And it's largely a question of familiarity, I think. It's been my impression, I don't want to overgeneralize this, it's been my impression, certainly during the RCA years, that because the exam pressure is so intense, people are tempted, I think, to take the exam too soon, really before they're ready to, before they've had a chance for the instructions in their head to die down to manageable levels. I mean, going back to the driving analogy, I'm sure every now and then you will remember mirror signal maneuver or those things that we talk about, but they don't dominate your thoughts. They only come into play when somebody hoots at you and makes you remember that you've perhaps behaved inconsiderately. So I think how shall I illustrate this? Another strand to my life has been Zen Buddhism. I've been Zen Buddhist since my early 20s, and there are lots of good stories in Zen, and there's one that's relevant here. All Zen Buddhist stories concern a young monk going to a master and asking for guidance. That's the setup in all Zen stories. And the one I have in mind is of a young monk who goes to the master and says, "Master, how should I lead a perfect life?" And the master replies, "First, make yourself perfect, and then live naturally." First, make yourself perfect, and then live naturally. In other words, put the work in early, learn as much as you can, gain as much experience as you can, and then on the day when you're faced with a real challenge, just rely on your instincts and do what comes naturally. And I think that philosophy, I think, also applies to young doctors learning consulting skills for the exam purpose. Yes, it could be funky and lots of instructions and going on in your head in the early stages, reading books about various models and practicing various techniques and stuff. But if you do that nice and early, so that stuff is then internalized and becomes automatic, you can then relax and then on the day you will just find yourself consulting in a nice, friendly, instructive way, rather than having to try to kind of control every word you say, because you're really just not, it isn't quite embedded securely enough. Does that make sense?
Yeah, I understand what you're saying. So to practice and refine the craft such that when they're doing it for the exam, they feel that they can do it almost as second nature that is coming.
Yes, I think that's right. Yeah. Yes. And I think with the SCA, that's going to be a bit easier too, because the candidates will be in more familiar surroundings. The examiner won't be visible. And in fact, the examiner won't actually be listening to them in real time. What's going to happen is that the candidates will have a series of role play consultations, like you and I having a conversation over Zoom at the moment, and that will be uploaded and recorded, and it will be watched at a later date by an examiner. So there isn't even the fantasy of an examiner listening to you as you're talking. So I think that will take a certain amount of the exam's performance stress away. I hope it does anyway. It certainly is intended to do that.
Hopefully. But one thing about that, one examiner would be reviewing the same case, and they will be reviewing the exact same case for a bunch of candidates. It can be difficult then, because then they might compare one and another, and then the marks might be relative, you see.
Yes, I understand that, and that's true. What, of course, candidates won't know, and I'm afraid will have to take on trust, is a huge, literally huge amount of work that goes on behind the scenes in examiner selection and training and quality assurance. Becoming a college examiner is not a piece of cake. It's it's being assessed and accepted onto the panel of examiners is quite a test in itself. The examiners all have calibration exercises. Their performances are monitored. Their statistics are monitored. They get regular feedback as to whether they're aligned with their colleagues. The exam employs professional psychometricians to analyze the performance of each individual examiner. They have regular training and monitoring sessions. It's as good as it can possibly be made. Ultimately, I mean, there's no dodging the fact that if you're assessing a complex skill, somebody's interpersonal behavior, ultimately it does come down to somebody having to make a judgment. And any judgment is essentially subjective. I mean, it isn't like a test of facts and knowledge where an answer is either right or wrong. It does come down to judges making judgments. And so all that can be done and all that needs to be done is to make sure that you select people whose judgment is reliable, that you monitor their performance and you keep them well trained, so that you can minimize the discrepancies between them, the variance, as it's called, and that is done with as much skill as is possible, as indeed the GMC regularly comments on when it does monitor professional exams.
So I think that would give some trainees some reassurance, because there's quite a robust process in vetting examiners, and hopefully
There really is.
In terms of the technology with remote consultation, that's something that is more popular now. What do you think have changed in the consultation skill set and models that trainees now need to incorporate?
Yes. Pre-pandemic, of course, probably about 70%, 80% of the GP's work was done face-to-face in surgeries, in the traditional consultation style. And probably 15-20% was done remotely over the telephone. And usually in times, it was usually who made that choice. But obviously with the strictures and the constraints that the pandemic imposed, almost overnight, that proportion shifted to at least 80% of consultations being done remotely. And I think a number of things have followed from that. One is it's taken patients quite a time to catch up with the fact that this is the new norm. At least it's not the norm, at least a much more common way of consulting your doctor. It suits a lot of people. Obviously, I mean, if you have as a patient, if you have a problem that can be dealt with just by a short conversation with the doctor, you don't need to take half a day off work and get the kids on a bus and so forth to go to the doctor just to ask for a repeat prescription. Of course not. And to be able to do some things remotely is a great advantage. There is a downside to it. Well, in fact, there are a number of downsides to it. One is that most of our patients tend to be elderly. Most of our patients tend to have more than one problem. And most of our patients patients are predominantly towards the more socially disadvantaged end of the spectrum. And these are the people, unfortunately, to whom remote technology is not so familiar. They don't all have their smartphones and their high-speed broadband and the rest of it. So I think that there's been a danger with a move towards remote consulting of disempowering or reducing access to perhaps the people who need care most, and preferentially to make ourselves preferentially available to the people who are okay with technology and have their smartphones and so forth, who actually need us least. So that's a kind of almost a kind of a political or an ethical dimension. In terms of the actual consultations themselves, I've seen candidates preparing for the RCA, handling the phone brilliantly, introducing themselves, doing their very best to make the patient feel at ease. But no matter how hard you try, with a phone link, you don't see body language, you can't see facial expression. It's hard to convey that sense of being alongside your patient when all you can hear is a voice at the other end. So I think there is a danger of missing quite a lot of the nuances that I think keep us on track in a face-to-face consultation. And video goes a certain amount of the way towards reducing that, but not the whole way. The video platforms that are around at the moment are not that great, and they are a bit unstable and so forth. And clearly, there's a clinical risk in a remote consultation where you can't examine a patient reliably. And so I think that makes that whole issue of safety netting, which we were talking about earlier, makes it much more important to make sure that we do ask about red flags, and we do always keep in the back of our minds, is this safe? Might I be missing something that's really important just because I can't see the patient? We have to remember that. And the other thing which I really am concerned about, which isn't necessarily the cause of remote consultation, but it's grown up alongside it, is the change in the way that patients are triaged before they talk to a doctor. Back in the old days, when I 100 years ago, the norm would be for a patient who wanted to talk to a doctor is to phone the receptionist, say I want to see the doctor, and the receptionist would ask one or two questions about was this urgent or not. But they wouldn't want to know too much detail about what the problem was. That the patient would quite rightly think that's the doctor's business and not the receptionist's. As part of COVID and the reaction to that and the growth in remote consulting, much more triage is now being done by people or by systems that are actually not up to it. I think it shouldn't be a receptionist's job, shouldn't be her business, and it certainly shouldn't be her responsibility to make clinical decisions about which member of the team the patient should see. That should be the patient's choice ultimately, or it should be the informed clinician. I think one of the things we have to guard against with the growth in remote consulting is to make sure that the process we have for deciding, is this a face-to-face, is it a remote consultation, if so, who with? We have to be very careful that we don't delegate that to a triage system that's actually not designed for it and not capable of making those judgments.
I understand that. So in terms of your advice to a GP trainee who is starting his career, what would you say to that trainee who might feel that it's very overwhelming general practice, and as you said, they're not getting the best of general practice when they started?
Yeah, it's a fair point, isn't it? I mean, I'm not going to put you on the spot and ask you, but at the moment, would you recommend one of your children, godchildren, whoever it is, to go to general practice at the moment? It's really difficult. But it's difficult in hospital medicine as well at the moment for other reasons. What I would say is this: if on the occasions that I get to talk to live audiences of GPs of all ages, and GPs, like all doctors, are perfectly capable of having a good old moan about how terrible things are at the moment, and it is. There's a huge amount of pressure. I'm well aware of that. And if you say to them, well, okay, well, in that case, why do you keep doing the job then? Since it's all so terrible. Almost all of them will say the thing that sustains them, that makes them keep doing the job in spite of all the difficulties, is the fact that when it's just you, the patient, one-to-one, the consulting room door closes, and it's just you and the patient. If that bit goes well and you enjoy it, and you're aware of doing something important, of perhaps being pivotal in that patient's life, of having something that's really valuable that they'll appreciate from you, if that bit goes well, it offsets a lot of the rubbish and the difficulty. And that's why I think sort of being able to enjoy the process of consultation, of knowing that I know how to have this conversation with somebody in a way that both of us are going to find satisfying. If you having that ability, i.e. consulting skills, I think is the biggest vaccination, if you like, against burnout that I can think of. It's the best way I know of trying to make sure that the job stays worth doing, that people doing it know is still worth doing.
Yeah, I think it's still very rewarding to consult patients and see how they're getting better and using your skills to make a difference in somebody's life. And although sometimes it might not be as you want it to be, but it's still something quite rewarding, and that's why many GPs carry on. What keeps you going, Roger? What is it that makes you keep teaching doctors consultation skills?
Oh, that's a tricky one, because I mean that is at so many levels. I can give you a theoretical answer in the sense that I think these things matter, and as long as I've still got some energy and some interest in them, and people ask me, then I'll carry on doing it as long as I feel inclined to. Because I think it's a flame worth keeping alive. You were kind enough to use the word legend about me in your introduction, which is a two-edged sword. I mean, I'm clearly aware that some of the stuff that I've written has found favour and people have found it helpful, and that's nice. I can't pretend it isn't. It's nice to be known. I wonder if I dare tell you this story, though. Yes, I think I probably dare. About 10 years or so ago, I had a small heart attack, from which I'm obviously fully recovered. But I take the usual amount of stuff that people take, beta blockers and all the rest of it after that, which means that once a year I have to get my repeat prescription reauthorized. And some years ago, I made the annual appointment for my prescription review. My regular doctor wasn't there, and the receptionist said, "Would you mind seeing the trainee?" Of course not. So I went in to see this poor girl who clearly recognized my name. And she said to me, "Roger Neighbour?" I said, "Yes." She said, "That Roger Neighbour?" I said, "Yes." And she said, "Oh, shit." Now, what I took from that was, okay, well, she was understandable. We both had a laugh about it. I thought that was rather endearing. What it did mean is that the stuff that I think matters was actually reaching that level of someone's career, and I'm not ashamed of that. I think if I can find just from the words that I use, or the stuff that I write from time to time, if that can reach people who are still early enough in their careers for that have an impact on what they regard as good consulting, well, I'm immodest enough to think that's still worth doing as long as I can.
Great. I think you're doing fantastic job, and still after retirement, and incredible. I think this is a book that many GP trainees would really get a lot out of. So any last words of advice?
I don't know about advice. It's still capable of being the best job in the world, isn't it? I mean, almost every day you could go into your waiting room and look around, and you would see one or maybe two people there who you will know that although the most of the stuff is routine and humdrum and undemanding, every now and then there'll be somebody in there who is really glad that at a particular time in their life that you were their doctor. And just knowing that from time to time is enormously valuable. And I think the idea of trying to be the kind of doctor who when it counts, can really have something to offer a person at a time of their life where they really need you. That's reward in itself.
I think this is a great place to end. Where can people connect with you, Roger?
My email is rogerneighbour, all one word, @gmail.com. I don't do social media. I never have no intention of. It's been my experience that if people want to find me, they usually can. And in all honesty, if people listen to this podcast want to get in touch, Roger Neighbour, all one word, @gmail.com will find me.
Thank you very much for your insights and your experience and perspective today.
Thanks, Erwin. It's been a great pleasure talking with you.
What did you think of this interview with Roger Neighbour? What have you learned from this video? Let me know down in the comment section. What have you learned from this video? If you found this video useful, then I'm sure you're going to get a lot from watching this video. Click the video to watch it. Take care, everybody. Bye-bye.